To our session today, from research to practice, HIF-PH inhibitors for anemia management in patients on dialysis. I'll introduce our speakers. There are two of us today. I'm Kirsten Johansson. I'm Chief of Nephrology at Hennepin Healthcare and Professor of Medicine at the University of Minnesota. And I'm really pleased to be joined by Dr. Stephen Fishbane, Professor of Medicine at Hofstra and Northwell Health. So with that, I think we'll get started with our presentation. So we are going to first talk about the clinical trials data, then I'll do that part, and then Dr. Fishbane is going to talk about practical aspects of using these medications, and then we're going to go over a complicated case and have some real back and forth. And then we'll take any questions that you have that don't get answered by those things. So that's the agenda for the day, for the next hour and a half. These are our disclosures. I just went over the agenda. I didn't realize that it had its own slide. These are the learning objectives for today. And again, you'll have all of these available to you in the app. And so I'm going to set the stage. I'm going to go through some the clinical trial data and also the physiology of anemia in kidney disease. So I'm going to talk just a little about anemia in general, and then again about the physiology and treatment, and the physiology of the action of HIF-PHIs. And then we'll delve into the trial data. And then at the end, we'll talk a little bit about some special considerations and populations. So first, let's talk a little bit about the prevalence of anemia and its treatment in CKD and end-stage kidney disease. On the left here is a slide just showing a cross-section of patients treated in the mHealth Fairview system in Minnesota, patients with stages 4 and 5 CKD. And this is just to show you that by the time people get to stage 5 CKD, a considerable number, about 30%, have anemia. And about half of those have hemoglobins less than 9 in the blue there. And then once people end up on dialysis, on the right is a slide looking at hemoglobin levels in patients treated with dialysis throughout the US, the entire dialysis population. And again, in the blue and red are the folks whose hemoglobins are less than 10. And even among prevalent dialysis patients in 2023, over 20% have hemoglobins below 10. Well, why is that important and what are we doing about it? This slide is looking at treatment of anemia. I'll start on the right this time, which again is patients from the general dialysis patients, Medicare fee-for-service beneficiaries. And if you look at people with stage 4 on the left and stage 5 on the right, the blue bar is people being treated with erythropoietin stimulating agents, and the red bar is iron, and the gray bar is transfusion. And so what you can see is that there's roughly the same amount of transfusion as there is ESA use in these patients. On the left are those patients from Fairview, again, where we actually know their lab values. And what you can see is that transfusion is not rare, especially if hemoglobin is less than 9, which is the bar on the far left here. So 15% of the patients whose hemoglobin was less than 9 on a lab evaluation received a transfusion within the next 3 months. In that population, and it was much less if their hemoglobin was higher. And I didn't put the slide here, but we did look at ESA. Oops, excuse me, what did I do? Did look at ESA use, and it was about 16%. So again, fairly comparable percentages receiving ESAs in the following 3 months after a low hemoglobin as receiving transfusion. And unfortunately, that also carries over into dialysis. This is just looking at red cell transfusion among Medicare beneficiaries. Any transfusion, 1 or more, is the blue bar at the top. And it's been coming down a little, but it's still well above 20% every single year. in these patients. So what I would say is that anemia is common in patients with CKD and dialysis, and our treatments are inadequate, at least if the goal is to avoid transfusion, which I think is one of our main goals. Let's go over a little bit about the physiology of it. This slide is a picture that I really like, showing the mechanisms of anemia in CKD. I think we're all pretty familiar with decreased EPO production in the setting of kidney disease as a major driver of anemia, and ESA administration directly addresses that. But I think that iron deficiency, either absolute or relative functional iron deficiency, are sometimes underappreciated as major contributors to the anemia of chronic kidney disease as well. And that's because of a fair amount of blood loss. Of course, we're all familiar with blood loss from the hemodialysis circuit, but even patients with CKD, advanced stages of CKD, often have subtle GI blood loss, as do dialysis patients. There's often decreased iron intake, so iron deficiency is not rare. And then functional iron deficiency is also common, mediated in large part by hepcidin. Normally, under normal conditions, hepcidin is secreted by the liver when there is enough iron around, and it acts as a sort of a brake on iron absorption and iron release. But in the setting of kidney disease and other things, inflammation can stimulate hepcidin even if there isn't necessarily sufficient iron around. And in addition, hepcidin is cleared by the kidneys. So hepcidin levels tend to be high in CKD, potentially even without inflammation. And again, that hepcidin then acts as a brake, turning off absorption through the gut and turning off release from the liver and the macrophages. And for any of you iron aficionados, that's based on ferroportin, interfering with ferroportin action. So let's turn to hypoxia-inducible factor pathway, because these new drugs, that's really the big focus of today, are acting on this pathway. So the hypoxia-inducible factor, PhD oxygen sensing pathway, plays a central role in cellular adaptation to hypoxia. And this pathway was elucidated and actually was the subject of a Nobel Prize award a number of years ago now. Hypoxia-inducible transcription factors, HIF alpha and HIF beta, are synthesized all the time. They're constitutively synthesized. But when there's oxygen around, oh goodness, pushed the wrong button. When there's oxygen around, they are normally, then HIF alpha is broken down by these prolyl hydroxylase domain enzymes in an oxygen-dependent reaction. They're hydrolyzed, and then they're marked for degradation, so HIF alpha is degraded. But when oxygen isn't around to participate, to participate in this reaction, then HIF alpha persists and translocates to the nucleus, combines with HIF beta, and then binds to these hypoxia-responsive elements on various genes, including the erythropoietin gene. So then the erythropoietin is transcribed, and erythropoiesis ensues. And so the prolyl hydroxylase inhibitors act essentially like hypoxia, and they block these enzymes, and they then stabilize the HIF, and erythropoiesis occurs in the same way. This is just to point out, and we'll have maybe a little bit of discussion about this later in Dr. Fishbane's presentation and in our case, but these hypoxia-inducible factors do have many targets, not just the ones that we're going to focus on today, but today we are going to focus on erythropoiesis and iron metabolism mainly. think this is the last diagram before I move on to the data, but a little bit more detail about HIF regulation of erythropoiesis. So HIF2 induces hepatic and renal erythropoietin expression, as we were just talking about. But in addition, it does promote the transcription of some genes involved in iron metabolism and transport. In particular, some of these duodenal cytochromes that may be involved in uptake and transport of iron, and ferroportin as well. The other thing that happens with use of HIF-PHI is when and erythropoiesis in general is that hepcidin is usually suppressed. That's an indirect effect, at least for the most part. Anything that produces erythropoiesis will tend to reduce hepcidin and potentially make iron more available, which makes sense from a biological point of view. Okay, I promised you clinical trial data, and now we're there. I'm really going to focus on vadadustat in this presentation because it's the only drug that's on the market right now in the US. But in some cases, I'll show you some other data just to either give you full context or to give you a little bit more detail about things like iron. Before we dive right into that, I wanted to give you guys a sense of, or maybe find out if you have already a sense of, how much data we actually have, how many patients participated in the trials that generated the data that I'm going to show you. So if you could use your app and use your response there to answer approximately how many total patients do you think were involved in the phase 3 studies for roxadustat, vadadustat, and daprodustat combined. And your choices range from 5,000, 10, 25, 50, or 75,000. Great, I can see some good responses coming in. We didn't put it so that you can see them because I didn't want you guys to be cheating and copying, and then everybody chooses the most common answer. All right, this is a good set of responses. Let's see what you guys thought. Wow, good. 25,000, that is correct. So you guys got it right. That's right. So approximately 25,000 in these 3 trial programs. And here's the answer in a little bit more detail. And like I said, we're going to focus this part of the talk and most of it on the vadadustat results. First, we'll talk about non-dialysis dependent CKD. I think the title of this talk was dialysis dependent, but I feel like it's a good idea to get a complete picture of the data. This is a schema of the PROTECT trials. There was a screening period, and then patients were randomized 1-to-1 ratio to either vadadustat, starting at 300 milligrams once daily, or darbepoetin alpha. And there was a 23-week, or basically 6-month, correction or conversion period, followed by a maintenance period for the rest of the year, 24 to 52 weeks. And within that time, the primary evaluation period was weeks 24 to 36. And then there was a secondary efficacy period, and patients continued throughout the trial and for 4 weeks beyond for safety evaluation. So looking at hemoglobin concentration, this graph is showing patients who were previously ESA untreated, and I'll go ahead and show the treated ones. And what you can see in both of these is that during the titration period, the patients who received darbepoetin, which is red, compared to vadadustat, which is blue, had slightly higher hemoglobin, but when they got to the maintenance phase, almost identical levels of hemoglobin. So vadadustat was non-inferior to darbepoetin for the treatment for achieving hemoglobin levels. Then the study also looked at major adverse cardiovascular events, and those were a composite of death from any cause, non-fatal MI or non-fatal stroke. This is a curve, again, vadadustat is in blue and darbepoetin is in red. And the overall hazard ratio was 1.17. The 95% confidence interval was 1.01 to 1.36. And so that's important because the non-inferiority criterion was an upper limit of the confidence interval of 1.25. So it did not meet the non-inferiority for MACE in the non-dialysis CKD population. This slide is just showing the, also they looked at an expanded MACE outcome, which was the one that we showed before, plus hospitalization for heart failure or thrombotic events. And again, a hazard ratio of 1.11 and that upper limit just 1.27, just above that 1.25 threshold. I just threw this one in. This study was not powered to look at death alone as an outcome, but just to show that there weren't large differences in death, I put this in as well. So here's just all three of the drugs, just to show. So roxadustat had an upper limit of the confidence interval for MACE. These trials all looked at a similar, if not identical, MACE events as MACE has outcomes. So 1.27, I just showed you in detail the vadadustat, and then daprodustat did actually meet non-inferiority with an upper limit of the confidence interval of 1.19 there on the bottom. Okay, well, let's move on to dialysis-dependent CKD. So these are the INNOVATE trials, and the design was very similar to what I showed you for PROTECT, so I didn't put another design slide in. And again, thankfully for people like me who have trouble remembering, they kept the color scheme the same. And so vadadustat is blue and darbepoetin is red. And so on the top are patients who were new to dialysis or incident dialysis patients. And on the bottom, people who had been established on dialysis or prevalent dialysis population. And what you can see in both of them is that, again, in the beginning, during the conversion or initiation period, the darbepoetin, the hemoglobin was a little higher in patients on darbepoetin. They came together, but even in the maintenance period, a very slight difference. It was minus 0.31, so 0.3 grams per deciliter hemoglobin lower in the vadadustat than darbepoetin for the incident dialysis patients, and minus 0.17 for the prevalent dialysis patients. But what I want to point out is that the bound for non-inferiority for hemoglobin was minus 0.75 for the lower limit. Neither of them were close to that, so they both meet the non-inferiority for treatment of anemia based on achieving a hemoglobin. Dr. Fishbane's going to talk about dosing and things like that, but I just did want to point out that when you think about efficacy for hemoglobin dosing, for hemoglobin achievement, it's going to be based on dosing and dose titration. And if you look on the right side here, this is the doses in those trials. And what you see is that the darbepoetin dose was pretty stable throughout the whole trial from the beginning to the end. But the vadadustat, remember, they started at 300, but there was some titration that really needed to happen in many patients. And so by the time it got to the maintenance phase, the average dose was around about 450 milligrams per day. Turning to the MACE outcome, I always have trouble with that because it's sort of like saying the ATM machine. I mean, the E in MACE is events, but just saying MACE sounds really weird. Anyway, these are the MACE. And what you can see here, the hazard ratio is 0.96 with confidence interval from 0.83 to 1.11. So easily meeting the non-inferiority for this patient population for MACE. And turning to the other agents, what you can see is Roxadustat had an upper bound of 1.26. Vadadustat, we just talked about, 1.11. And daprodustat had a hazard ratio of 0.93, and then the upper bound was at 1.07. So did meet the non-inferiority criteria for patients who are dialysis dependent. So that is the big trial results. I wanted to drill down just a little bit before Dr. Fishbane gets to what you really want to hear about how to dose these drugs in the real world, and just talk about a couple of special populations and special considerations. This is busy, I know, but I'll walk you through it. And I won't even walk you through all of it. I'll walk you through some of it. This is a secondary analysis of those vadadustat studies looking at iron parameters. So A, B, C, D, if you see those, are the different patient populations, ESA untreated from the 4 trials, basically. And if you look at the far left, let's see if I can do this time without advancing the slides. Look at the far left. What you can see is that this is total iron binding capacity. And so what you can see is that pretty consistently, the patients that received vadadustat had an increase in their total iron binding capacity, whereas those that received darbepoetin did not. I don't want to walk through all of these, it's too much, but if we just focus a little here on the hepcidin as well, what you can see is that it did go down in general for all the patients, and we talked about that erythropoiesis by itself tends to reduce hepcidin, but it was reduced to a greater extent pretty consistently in the vadadustat recipients compared to the others. And so the authors of this study concluded, based on these data and then some other things that they also measured that I didn't show you for the interest of time, that this was indicating improvement in iron availability. And so I think this is intriguing. Turning to actual trial data on iron, there's very little, actually. The trials, I showed you the big trials with vadadustat. They really weren't designed. They were designed to evaluate the effects of these new drugs compared with ESAs, but they weren't designed to address iron parameters or iron use for the most part. And I think that's for a number of reasons. And, there are really large international differences in iron management, which I didn't even realize until being involved in some of this. But some countries use mostly oral iron, even in dialysis patients, for example. The ferritin limits that people are willing to tolerate are hugely variable as well. The studies had different iron protocols too, which makes it hard. And some of them didn't really adequately monitor iron use either. But this data comes from the Sierra study, which was one of the roxadustat trials in dialysis patients. And it was done in the US as well, which I think for our purposes at least is nice. And it gives us one little snapshot of data. So all the patients, so their iron protocol was that all patients were encouraged to take oral iron. And then IV iron was allowed if patients either didn't respond adequately or couldn't tolerate it, and then by their parameters, by their T-stat and ferritin, they were iron deficient. And so those patients then received IV iron until their iron was replete again. And so these are the results on the right. It's roxadustat now, and they seem to have used the opposite color scheme. So blue is EPO, and red is roxadustat. And so what you can see on this slide is, over the weeks, the percentage of patients, or rather the mean IV iron use, was slightly lower throughout the trial in those who were on roxadustat than those who were receiving ESA. And that difference was small, on the smaller side, but was statistically significant. So I throw that out there for you. I know Dr. Fishbane's going to talk about peritoneal dialysis patients, and so this is just a little bit of data specifically addressing that patient population, a paper that was published in 2023, looking at the subset of 309 peritoneal dialysis patients from the INNOVATE trials, vadadustat. And just to show on the left the hemoglobin results. So the differences, the two bars on the far left are the evaluation period. So very slight difference, but well within, but not statistically significant. So similar to the primary results. And then on the right is just showing how they were throughout the trial. So very similar hemoglobins in both groups. And this is the MACE curve. I really don't want to focus on the exact hazard ratio numbers because, again, this was 309 patients, so nowhere near powered to look at it, but just to show you how it looked, not all that different. And the point estimate here was 1.1, so similar to the point estimate. What was that? Similar to the point estimate for the whole trial. Okay, one last slide. And then we'll go to Dr. Fishbane. So this is a slide looking at dosing of roxadustat, again, just because these data are available for roxadustat more so than vadadustat. On the left-hand panels are quartiles of erythropoietin resistance index. So basically, the people on this end were not needing very much erythropoietin, and these people were needing more. And so then the red line is the roxadustat dose. So what you can see is that people who needed more ESAs at baseline needed more roxadustat than those who needed less. But the difference wasn't that great compared to the difference in ESA. So this was the point that the authors highlighted, that there's a much steeper increase in the amount of ESAs that you need. And then here is looking at iron sufficiency. So these folks down on this end had low TSAT. This box is low TSAT and low ferritin, for example, and this is high of both. And so what you can see is that there wasn't that much difference in the need for roxadustat, even for people who were overtly iron deficient, compared to those who were less so. But again, that was less true for ESAs. So people who were iron deficient needed quite a bit more ESAs than those who were not. So these are not randomized data. These are observational data from the randomized trials, but I think it's intriguing. And I hope that we'll see more data coming out on iron use with these these drugs going forward. So with that, I want to just thank you for your attention. I hope that I convinced you that anemia is common. Anemia is still inadequately treated in this day and age, not just in people with CKD, but even in people on dialysis. I really thank you for bearing with the diagrams of the physiology. And we have clinical trial data from large numbers of people to show that HIF-PHIs are effective in the treatment of anemia, and in the case of dialysis-dependent CKD are non-inferior to ESAs in terms of their MACE outcomes. So thank you very much. Now I'm delighted to turn the podium over to Dr. Fishbane. Thanks.
Thank you, Dr. Johansson. And so I'm going to be moving forward and trying to speak a little bit more about the clinical practice use. So that was, it's very hard. There's a tremendous amount of data that's out there, and that was an incredibly good summation of what we know from the studies that have been done with these agents. I do want to disclose some relationships that I have, including, working with development at one point with all the companies that were developing HIF-PHI drugs. I'm also part of the KDIGO anemia panel. So I'm going to try to speak about availability of the drugs, try to understand in dialysis and why dialysis. Well, we'll come back to that. Talking about ESA hyporesponse, which if it's a subject that sounds boring to you, please stick with me because I think you'll see that it's interesting, it's relevant to us on our everyday practice. And the potential in inflammatory states, which again, very important subject that we don't talk a lot about. So let's start off with a question for you. So in what patient group should this new class of agents, HIF-PHIs, be used with caution? Should it be patients with active retinal disease, patients with phosphorus that's difficult to control, PD patients who are rapid transporters, patients with a fear of needles, or all of the above? Please enter your answers now. Okay, we have over 50 answers in. So the most common answer was people with active retinal disease, followed by all of the above. And the right answer here is, and I'll come back to this later, about why active retinal disease might be a potential concern. Patients with phosphorus that difficult to control. Sorry, just a distractor that I came up with, but there is no relationship between HIF-PHIs and phosphorus. PD patients who are rapid transporters, sorry again, bad choice on my part because again, not related. There's nothing to do between one and the other. But the last one, was actually really a right answer, but not the right answer. The right answer is active retinal disease. But if you have a fear of needles, these are oral medications. Vatidustat's an oral medication. So think about that. And we'll come back to why it's relevant for today's discussion. So from all of the data that you just had the opportunity to look at, the U.S. Food and Drug Administration has to make decisions on purely the balance of benefit and risk of the agents that they're looking at. And the sponsors for these drugs all submitted new drug applications, and only vadadustat and daprodustat were approved, and only for dialysis use. So you saw in the data that Dr. Johansen showed you, there were some issues, a little bit hard to understand in the non-dialysis populations, but there you go. So we've got dialysis approval for 2 of the drugs, and then GSK, which markets daprodustat, announced that they were going to focus priorities in other areas. They were going to withdraw from the US market. So if it seems like we're talking a little bit more today about vadadustat rather than the other HIF-PHI drugs, it's because in the US, that's the drug that currently has an FDA approval and is available for use. Now, the indication for Vafseo, and I'll say the brand name once there so you can connect it, but vadadustat is indicated for the treatment of anemia due to chronic kidney disease in adults who have been receiving dialysis for at least 3 months. So that's an unusual statement of indication. Think about all the drugs that you use in treating people who are on dialysis. You can't think of another drug where it says wait until the patient's already on dialysis for 3 months. And the rationale here was FDA felt that among the thousands of patients that were studied here, there weren't enough in the first 3-month period for them to make judgments about safety and efficacy. And I would question that a little bit, only in that, for all the drugs that we have, from apoetin alpha to drugs like cinacalcet and others, are there any other drugs that had enough patients that were evaluable? So I think it was kind of an unusual decision, and it complicates treatment a little bit. So I think it's relevant for us. And I'm going to come back to that to try to understand that a little bit better. So we saw the evidence for vadadustat use. We saw the INNOVATE trials, Dr. Eckhart as lead author, showing that vadadustat in the dialysis population with a clear demonstration of efficacy and a safety that was similar to darbepoetin alpha. So that's good. That meets the criteria for approval, and the drug was approved. But you may be asking yourself the question, wait a second, darbepoetin alpha, that was the drug from the TREAT study, 2008 TREAT study. Darbepoetin alpha is used compared basically to placebo, and it showed an increase in strokes and cardiovascular events and thrombotic events. Don't you want to show that you're safer than that drug? And so that there was a lot of speculation before the ends of these studies. And I want to remind you of something, and that's that in the studies that you're familiar with, things like the TREAT study, the CHOIR study, the CREATE study, normal hematocrit cardiac trial, those were studies of normalization of hemoglobin. Those were studies where authors were trying to look at if you raised hemoglobin to 13 or 14 or 15 or even higher, would you get improved outcomes for patients? And it seemed right, I have to admit, when we first started those kind of studies. But the only place where we've seen necessarily demonstrable safety issues with ESAs was targeting levels of 13 or higher. We don't believe that ESAs are necessarily not safe with a hemoglobin target of 12 or 11. So in these studies, you've got vadadustat compared to darbepoetin in a range of hemoglobin targets like 11 or 11 and a half, where there isn't any known safety issue for darbepoetin. So you didn't want to see improved safety. You wanted to see that it had about the same safety with an oral drug that you're giving to a patient, treating the patient's anemia. And that's what we found, as you saw clearly in Dr. Johansson's presentation, that the safety was non-inferior compared to darbepoetin. Was the population generalizable? We always have to ask ourselves that. Was the population studied some quirky population? But no, these are the patients that we treat. It includes incident patients, it includes peritoneal dialysis patients. And what I always look for, was there a lot of patients with cardiovascular disease? And yeah, in fact, there were a lot of people that had cardiovascular disease. So I think that I was going to put up the patient characteristic table from the studies, but here I'll ask you to take it on faith that a very representative population that sure looks like the US population of dialysis patients that we treat. So with the approval for these drugs, how are we going to use them? So vadadustat approved for use for dialysis in the United States after 3 months. Where are the places where you first might want to treat patients? So ideally, the oral route would have made this drug so ideal in the non-dialysis CKD population. We just saw Dr. Johansson show us the number of people who are transfused compared to treated with EPO, iron, and all of those transfusions. You just have to worry about developing anti-HLA antibodies, the effect on subsequent transfusion. What a tremendous opportunity it would have been for non-dialysis approval for this drug. Maybe someday we will see that, but that's not what we have right now. What we have is approval in dialysis. So let's think specifically in the dialysis population. So I'm going to focus on home dialysis, on patients who have ESA hyporesponse, on the iron effects of this and other HIF-PHI drugs, which I think creates some opportunities, and perhaps other areas that might be important. So let me go back, and I apologize because this is a little bit repetitive, but I want to remind you about the HIF system how it works in normal biology, and similarly, when we stabilize HIF with the use of a drug like vadadustat, what are the things that we're accomplishing? So if there's not enough oxygen around, well, it's natural that one of the things that the body would do would to increase erythropoietin production. You want to have more red blood cells, more ability to carry oxygen through the body. And sure, HIF-PHIs give you an increase in erythropoietin. But as you saw before, it increases a whole variety of iron proteins as well. So again, these are substances that are there to protect the cell and tissues against the effect of hypoxia. So if we're stabilizing this system, we're getting both erythropoietin production and a coordinated increase in iron proteins so that both erythropoietin, iron availability are all there. So if it's normal biology, if you fly to Denver at 5,000 feet elevation, this is all going to be activated in your body. I don't think in Boston it's being activated right now, but go up to 5,000 feet or go up to Breckenridge or Mexico City, and all of this gets activated as a way of being able to protect against the less oxygen availability. And in addition to all that, something that's really important is the ability to reduce hepcidin. And again, hepcidin is the master regulator for iron in the body. And when it's present, which is often true in our dialysis patients, it reduces the amount of iron that can be used to make red cells. So how many times have you seen a hemodialysis patient and the ferritin value is, say, 800, and yet the transferrin saturation is 6.5%. And forever, I know I would be asked this when I would do a lecture, why do we get this crazy disparity in the numbers? And this is all because of hepcidin. So many of our patients have increases of hepcidin, which locks away iron in storage tissues, and the ferritin value goes up as a reflection of storage iron, but iron doesn't get released into the circulation. So serum iron or transferrin saturation go down. And when you see your patient who has the 800 ferritin and a 6% T-sat, you should ask yourself, is there something going on here that makes me think about inflammation? Is there perhaps a smoldering infection, or is there an old graft in the arm that perhaps is infected, which has been shown, as an important cause actually. So multiple effects that could be important. And what did we actually learn about these iron effects of HIF-PHIs from the studies? So you saw that TIBC, so the ability to carry iron in the circulation, goes up demonstrably with all of these drugs. So HIF-PHIs compared to ESAs improve the ability to carry iron in the circulation. Serum iron goes up, hepcidin is reduced, and serum ferritin may actually go down a little bit, but that's a reflection of iron that's being used from storage tissues to be able to make new red blood cells. So both biology in the previous slide and the clinical data both show us the same thing, that the HIF-PHI drugs, like the HIF system in general, tend to work to improve iron availability. What's harder to say, as you just saw, is does it affect the amount of intravenous iron that patients are treated with, which maybe is not the most relevant question, and yet, I think for some patients, it might be particularly important. So let's flip over now, and let's talk about home dialysis. So for example, peritoneal dialysis. We have a large PD program, so this is interesting for us, and I know for a lot of you. Patients on ESAs, they lose some of the home advantage of being on peritoneal dialysis. We have a lot of our patients that have to come back during the month, sometimes more than once, for ESA injections or for intravenous iron infusions. So there's certainly good reason to think that an oral HIF-PHI like vadadustat could preclude the need for the patient to make the extra trip. It's an oral medication. My peritoneal dialysis patient, I could put on an oral anemia treatment that will treat the anemia and maybe also prevent the need to come back in for intravenous iron infusions. This seems like a very natural. You ask yourself, where's the first place that I would potentially treat with vadadustat? I would think that this would be the first place that you would probably look at. Home hemodialysis, for us, it's a little bit trickier because we don't have a very large program, and we do some of the EPO and IV iron at home with the patient. So that's a little bit more ambiguous in terms of whether there would be an advantage there. What about the effectiveness in peritoneal dialysis? So if the patient comes into the unit, well, at least you know you're injecting the drug. If you send the patient home on oral vadadustat, for example, will it work? And as Dr. Johansson showed you, and look at this slide, if you look at vadadustat compared to darbepoetin in peritoneal dialysis patients, the hemoglobin concentration over 20 weeks, 60 weeks, 80 weeks, 120 weeks is basically about the same. So I look at that and I think, am I going to keep having my patients come in for injections when I can treat them orally, get the same hemoglobin effect? This is other data. I think it was from Taiwan. Hu et al. It's 86 patients. It's a smaller group, but they show you the same thing. In this case, it's roxadustat. It works about the same. I mean, the hemoglobin is statistically significant, a little bit higher, but that could just be a dosing effect. But in addition to that, they show in this study the reduction of hepcidin just for additional, I think, interest. But it's more, I think, evidence in proof of the idea that using an oral agent in peritoneal dialysis patients could be a choice, an option that you have available to you. Now, flipping from peritoneal dialysis over to in-center hemodialysis. So here, what is the opportunity? Where am I going to potentially be treating patients with a drug like vadadustat? And again, we've got to think about the FDA's 3-month waiting period. You need to wait until the patient's on dialysis for 3 months, and then you'll be thinking about which patient might be one that I would think of. It appears to me that probably what we're going to be thinking is the person who's not doing well on EPO. That would be the most logical, unless the patient has some obvious problems in terms of treatment with erythropoietin analogs. So I think that'll be a common scenario. So let me remind you about ESA hypo response. People have come up with all kinds of mathematical equations, including me, that they're not needed. You can think of ESA hypo response. It's your patient on hemodialysis. You know this patient. The hemoglobin level is usually below 10. And if you try to get it above 10, you're using high doses of ESAs. And it's right there in the FDA label. They say use as low a dose of ESA as you can possibly use because of the associations of ESAs at a high dose with increased mortality. So these are the patients with ESA hyporesponse that I think I'd be considering how could I potentially get improvement in these patients. If you're not aware of the relationship between ESA hyporesponse and mortality risk, there's a lot of studies that are like this one. This one just happens to show as you move from left to right, for people that have a greater degree of ESA hyporesponse, there's an increased risk of death in those patients. Now, this is observational data. This could not necessarily be causal. It could be that these are sicker patients, that there's something else different about these patients, so they need higher doses of ESAs. Let's be a little careful how we interpret this. But I could show you other data that shows a very clear link that's hard to separate between higher ESA doses, risk for mortality, and it's always intrigued me. Injecting a natural hormone at very high doses and the serum concentrations that you get has always been a concern. I've written about it. It's always been a concern of mine before HIF-PHIs were even a thing. So, it's something that we should consider. In hyporesponse, we can't think of patients as either being an ESA hyporesponsive or not patient. About 50% it's intermittent, about a quarter it's chronic. They're always hyporesponsive. And then you get patients that one time they'll be hyporesponsive, other times they're not. There's different patterns, and important to recognize if you want to help the patient because the patient has unresolved symptoms or the patient, you're concerned about the mortality risk. So traditionally, what are the things that cause ESA hyporesponse? And is there a reason to think that HIF-PHI drugs might address those? So forever on the boards, they would ask the question, what is the leading cause of hyporesponse for ESAs? Easy, you went straight to iron deficiency, circled it, moved on to the next question. And that's true. Iron deficiency causes a lot of ESA hyporesponse, but you know what? We use so much intravenous iron in the US right now that I don't know that it's really still true. And I know, I don't think I've seen this, as a board question more recently, but HIF-PHIs probably improve iron availability. So if that is the leading cause of hyporesponse, well, yeah, we would expect hyporesponse to be benefited if it's caused by iron deficiency. I think inflammation is currently the most common cause of ESA hyporesponse. There is a lot of occult inflammation in dialysis patients. It's a great subject of interest, and there's some evidence that HIF-PHIs may work just as well whether or not inflammation is present. If you treat anemia and the patient has inflammation, do ESAs work as well? No, ESAs do not work well in the patient that has inflammation. And I want to call your attention to this study. So, let's see if I get the laser to work. If you look here at the hemoglobin level of patients treated with apoetin alpha, you see that for patients with a high CRP level, the hemoglobin level is substantially lower in this study, but in lots of other studies as well, in patients that have inflammation, whether it's CRP, whether IL-6 or other markers for inflammation that were used. But notice this, that with treatment with ESAs, not only is the hemoglobin level lower if inflammation is present, but you have to keep dialing up the dose of the ESAs in order to be able to even keep up that lower level of hemoglobin. Inflammation is a powerful block for a whole variety of biological reasons against the ability to treat effectively with ESAs. What about HIF-PHIs? So this is now one of the HIF-PHIs, roxadustat. And if we look at the hemoglobin level, you'll see that it's about the same. Compare this, by the way. I mean, the hemoglobins start at about the same level. They jump up higher with roxadustat. I think that was a dosing issue, but there's no hemoglobin penalty. It works about as well whether the patient's inflamed or not. And look at this. Look at this. The ESA, the HIF-PHI dose, the roxadustat dose, instead of going up over time, actually drops as you get a hemoglobin that's about the same. There is no dose penalty with HIF-PHIs like there are for ESAs in the inflamed patient. This is data from daprodustat that shows about the same, and because my time is running a little bit tight, I'm going to go past there. But in inflammation, there's certainly great biological reasons why we would have expected before these studies ever started that HIF-PHIs would perform well in people who have inflammation present. We have data that are limited, but they're supportive. Again, I think inflammation probably is the most important current cause of ESA hypo-response. And the studies that we show are promising, and there's tiny studies that show if you take your hyporesponsive hemo patient and either replace the EPO with a HIF-PHI or add the HIF-PHI to the EPO, the patients do really well. But honestly, it's like 8 patients in one group, 10 in the other. I wouldn't even put that up on the screen. I would say that it at least looks promising, and it should be promising because there's good reason to believe that it should be effective. So the conclusions on inflammation, I think there's a really good use case here, and I'm going to go to the bottom, which is my opinion. If you look at your hemodialysis patients, you're 3 months in to the patient being on dialysis, and ESA hyporesponse is present, you can add a HIF-PHI to an ESA and see how the patient does. But I do want to say that KDIGO recommends not doing that, but replacing the ESA with the HIF-PHI in that setting, not using the two together. So in terms of dosing, rather than the specific dose, which you can look up, let's talk about daily dosing. So vadadustat, you've heard repeatedly that it's an oral everyday treatment. But in a hemodialysis patient, do you really want to give a drug that the patient's going to take orally every day when your anemia can be well controlled by doing injections? The hemoglobins will be good. You don't want some patients that are not going to be taking an oral agent. So there's been interest in studying, and there's all the reason to believe that these drugs should work just as well 3 times a week. This is a study from Toka et al., and it shows you basically if you dose 3 times a week with vadadustat at the dialysis unit, you get just as good an effect as you would get in this study with Mircera. So over the course of 50 weeks, 3 times a week treatment, yeah, works just as well. And there's other studies that show the same. So my opinion, if you have somebody on 3 times a week for intermittent hemodialysis, I would give the patient 3 times a week vadadustat at the dialysis unit, as opposed to PD or home hemodialysis, where I would just dose the patient daily. KDIGO guidelines. So KDIGO's most controversial guideline, I'm on this panel, was 3.1.1. This is the new KDIGO guideline, and it says in people with anemia and CKD, we suggest using an ESA rather than a HIF-PHI as first-line therapy for treatment of anemia. So maybe that means in the first 3-month period, but I think that that what the intent here was to say that because we have 35 years of experience with ESAs, there was a little bit more comfort until we know more about the HIF-PHIs. I don't necessarily agree with that position, but that was the approach of KDIGO. The European best practice guidelines are a little bit more promotive of HIF-PHIs. In peritoneal dialysis patients, they recommend the use of the agents to avoid needle sticks. And for hemodialysis patients, again, focusing on ESA hyporesponse, where they do recommend use, they do recommend caution in certain populations, like people that have retinopathy, that's active retinopathy. We'll come back to that, but also people with polycystic kidney disease, and we will come back to that as well. So I would say, look, ESAs have been around for 35 years, and we're all different. If you're a person that wants to wait on new drugs and understand them better, you like the fact that ESAs have been out there for a long time. But look, I think that there are well understood ESA safety issues, and I'm not sure they're that different, but maybe we understated them a little bit in the KDIGO guidelines. The HIF-PHIs are newer. They're oral drugs. And like any new drug, we can't be sure that over the years there won't be other safety issues that come up. So depending on your sensibility, you may like the fact that 25,000 patients have been studied over the years and that there's meta-analyses that have looked at this. If you're an early adopter, if you're more comfortable with new agents, then you're going to be comfortable treating patients. At Northwell, what we're going to be doing, peritoneal dialysis patients, we're going to be switching almost everybody to try to take advantage of the fact that these are oral agents. In hemodialysis, we're still kind of trying to figure it out a little bit. So I want to conclude by saying, number one, I think that for 36 years, we really have not had a choice. It's been ESA therapy, and there's been patent protection that has gone on for years and years and years. It's a good thing to have the ability to consider the individual patient and to be able to make choice together with the patient, discussing some of the issues that we've discussed today. I think oral treatment for HIF-PHIs in the PD and home hemo patients is an interesting consideration, which we'll take advantage of. Definitely valuable to have options for ESA hypo-response. And please be aware that while we debate these things and go back and forth in the United States, over the past few years, HIF-PHIs given orally to treat anemia are being used very extensively in Asia, Europe, South America, in patients with non-dialysis CKD, not approved for that purpose in the US, in people on dialysis. We saw data at ASN this year from Japan with huge numbers of patients. It's out there and it's available. So thank you very, very much for your attention. And at this point, we're going to go to a challenging case discussion. And Kirsten, do you want me to read this or do you want to? Yeah, I guess we can control it. Let's see.
Oh, it is. All right. Dr. Fishbane came up with a doozy of a case for us today. I'm just going to warn you. There's a lot to talk about here. You want to, so we're going to, I'll read the first one. You read the next one. We're going to discuss a case with a patient who has a history of renal cell carcinoma in remission. So the question is, do you usually treat with ESAs differently in this situation? No, the disease is in remission. Yes, I would avoid ESAs in patients with a cancer history. I would treat with ESAs, but more conservative hemoglobin target and lower ESA doses, or it depends on the type of cancer. Please respond, and I'm going to be really interested to find out what you guys all do, because I know what I do, but I'm kind of making it up. All right, I'll wait a second till we get well into the 50s. Okay, should we advance? Survey says, okay. So the number one answer, there's not one marked as a right answer or wrong answer here. I should have said that from the beginning. But it looks like not the majority, but the plurality, I guess, would treat with ESAs, but to a conservative hemoglobin target and lower ESA doses. But there's still 20% of you who avoid ESAs in patients with cancer history altogether, it looks like. All right, well, that's really good context for this case that Dr. Fishbane's going to present.
And we'll come back with, a continued discussion on that, but I'm not sure that there's any right answer there. I wrote that question and intentionally kind of left it a little bit ambiguous because I know you struggle, because I struggle, you struggle, with what to do with cancer patients when we're using ESAs, and that'll come back again. So we have a discussion case for you, and think about some of the issues that are here. And Dr. Johansson and I will go back and forth a little bit on this one, but this is a 56-year-old man who's on hemodialysis due to polycystic kidney disease. He's been on Apoetin alpha for 6 months. He's been hyporesponsive. The use of vadadustat is being considered. 3 years prior, he had a partial nephrectomy due to renal cell carcinoma, which has been in apparent remission since that time. A month prior to starting hemodialysis, 7 months ago, he had dyspnea, he was short of breath. It led to a diagnosis of coronary artery disease. There was a cardiac cath. They found 2 significant stenoses. They were both stented with subsequent dual antiplatelet therapy. And now over the past 3 months, the hemoglobin hasn't been above 10. It's currently at 8.8. A weekly Apoetin alpha dose rising to 21,000 units. He complains of fatigue and feeling cold. A full evaluation has not revealed an obvious cause for this EPO hyperresponse. So let's throw a question back to you now. Considering this case, what would you do next for this patient's anemia? Would you increase the Apoetin dose further? It was 7,000 units 3 times a week. Would you add vadadustat to the Apoetin? Would you discontinue Apoetin and initiate vadadustat? Or would you do something else? Do you have another idea that you might have for this patient? Please vote now. So the most common answer here was discontinue Apoetin and initiate vadadustat, which I think is what I would do, but we'll come back and discuss it together. Add vadadustat to the Apoetin, 17%. Some other idea, 14%. So we're going to call on you. We actually checked who voted on that, so we'll see what. Or increase the Apoetin dose further. It's not the highest Apoetin dose ever. You can go a little bit higher than that. I don't like to go above 20,000 units a week, but I don't know that that's necessarily a right answer. So before we go to the case, does anybody want to talk about their answer? Or, raise your hand if you have anything that you'd like to get out there right away on that one. Yes.
Show that. By the way, I'm Leighton James from, Augusta, where the Masters is going on now. I don't play golf. I would probably want to increase the EPO, but you could also go the other way. The concern with the HIF stabilizers is that many of the cancers depend on HIF. That's the whole idea behind the Warburg effect and using alternative metabolism. So the studies didn't show that, but I have a concern, and I don't need long term to show that. That's the only concern I have about them.
And it's a really good question, and it's one that we're going to speak about back and forth, and we're going to want to hear your thoughts on it as well as we get there. So that is a really nice lead for us to jump back to the case. And so let's think about this again. The start point has been, I think, one of the issues that has worried us with HIF-PHIs, which is what to do with people who have polycystic kidney disease. And the issue here is that there's certain aspects of cyst formation that do seem to be dependent on the HIF system. So the drugs are not approved right now, Kirsten, in patients in non-dialysis CKD. If you did have the drug to use in a polycystic patient who wasn't on dialysis, would you be concerned about the potential risk with polycystic kidney disease with a HIF-PHI agent?
Absolutely, I would. And that's what I was going to say is in that setting, I would be concerned. I would be concerned about increased cyst growth and possibility of more rapid decline of kidney function. I don't think we have really good data on that, and we may not get it because I think there will be a lot of concern. So I would, but in a patient who's on dialysis already, and not dependent on that kidney function, there I would have less concern. Unless the patient were having a lot of pain from expansion of cysts, I'm not going to say it would never be a concern, but for a stable dialysis patient, not symptomatic from their polycystic kidney disease, this one doesn't give me a lot of trouble. I don't know what your thoughts are.
Yeah, no, I kind of agree. So the non-dialysis patient who has polycystic kidney disease, again, not approved for that purpose in the US, so it's a little bit of a discussion that maybe isn't even needed. In the studies that you showed us, the non-dialysis studies, were polycystic kidney patients excluded,
I think they were from at least some of the studies. But I don't know that they were excluded from all of them. I'm sorry, I should know that, but I'm not sure.
Yeah, and so, right, I mean, this is dialysis now. It's a patient who's on dialysis after having polycystic kidney disease. And, when I wrote this part of the case, I definitely felt the same way and agree with you that I'm not sure that I'm concerned once the patient's on dialysis. Although I have to say that 3 weeks ago, for the first time in about 20 years, I had a patient on dialysis who had bilateral nephrectomy because the kidneys had just taken over his body. They were just so huge with the cysts. But polycystic kidney disease after being on dialysis, I guess we're a little bit less concerned. Does anybody feel differently about that? If you know that HIFs may affect cyst growth potentially, at least theoretically, if the patient's now on dialysis with a past history of polycystic kidney disease, anybody concerned about that? Or do you have further? We'll have, by the way, questions and answers we're going to be doing right when we're done with this. But any other concerns about polycystic kidney disease? And I don't see any. So I guess next we get to the issue of cancer and anemia treatment. So this one, Kirsten, we've got 3 years prior, he had a partial nephrectomy due to renal cell carcinoma. It is in remission right now. So maybe we could start more broadly, getting to the questions from before and the polling question. In terms of cancer in general, and just using current ESAs, do you change the way that you do treatments? If there is maybe active cancer is not the right question, but if the patient has a history of cancer?
I do, but it depends on the type of cancer and the treatment that they've had. So I liked that choice there. This particular case, in a renal cell carcinoma that's been presumably, we don't have the entire medical history here, but presumably removed. So the disease is actually gone and under remission. That would give me less concern, perhaps, than a patient who'd had a breast cancer diagnosis that had previously been metastatic, because then I'd have more concerns. The likelihood that might recur would be higher. And that's not with a lot of data. My sense about, there's data that ESAs as well, cancer outcomes are worse. So it's not that HIF-PHI, there's a concern, and ESAs there's not. I'm sure you all know that. But I've always thought it's about VEGF and oxygenation of these tumors. And so with a low tumor burden, you could certainly argue to use it, but it gives me more concern when I'm worried about a young person whose cancer might come back. What do you do?
Yeah, and I agree. And I think that the most common answer that we saw was continue to treat. So ESA world, you're using an ESA, but maybe a little more conservatively. And within 5 years with the history of cancer, I don't usually go, and we have protocols where we don't go above 10 for a hemoglobin and try to limit the ESA dose to some extent. Remember, if a patient is currently undergoing active treatment that the FDA does recommend that it depends on whether you're trying to treat to a cure or not, in which case they say don't treat with ESAs. But in dialysis patients, that's complicated because they really don't have any EPO on board.
No, it's really hard. I have a patient right now who's relatively young, but requires so much transfusion without any ESA at all that we have gone to a conservative ESA protocol. So I think you do have to take these cases one by one, whether it's ESAs or whether it's in this new environment, HIF-PHIs.
Well, let's deal with the renal cell carcinoma HIF-PHI part of it. The most common type of renal cell carcinoma, you all know, is clear cell renal cell carcinomas. And it is a tumor that is dependent on part of the HIF system, a suppressor of the von Hippel-Lindau protein. And there's actually, while we're talking today about HIF stabilization, there are drugs being used right now by our oncology colleagues to inhibit HIF. The exact opposite. We're stabilizing HIF. They inhibit it in renal cell carcinoma. So I guess this particular tumor worries us about HIF-PHIs, and we probably would be staying away from it. The studies, I guess I would ask you, it's a lot of patients that were studied here. It's not like the studies went on for 25 years, but there's fairly long follow-up. Is it enough for us to look at the HIF-PHI studies, which didn't show much of any signal towards cancer? Is it enough to satisfy us that that's not going to be an issue? Let me change to English on that. Did we study patients long enough to feel safe about HIF-PHI use?
I mean, I think not yet. That's my opinion. Some cancers take a long, long time to develop. It's not to say that I'm saying we shouldn't use them, but I think we need to have ongoing surveillance about that. That's my opinion.
Yeah, that makes sense. I don't know. Is there a registry? Are they going to try to follow long-term?
I know that were the GSK drug to have stayed on the market, there was a requirement by the FDA to monitor. I'm less sure of what the situation is with vadadustat.
Okay. We're going to get to your questions in a couple of minutes, but let's deal with the coronary artery disease part of this. And so we saw the dialysis data in terms of major adverse cardiovascular events. It didn't look like there was a difference between HIFs and ESAs in terms of cardiovascular risk. So we could probably talk about anemia treatment more broadly. And what do you do with somebody that's had a recent coronary event? Because this comes up all the time. Or is that a fair assumption? Or do you think HIF-PHIs should be thought of separately in terms of cardiovascular events and recent disease?
Yeah. Well, I liked the point that you made about, were these patients representative of our patients? And were there a lot of people with cardiovascular disease in the trials? Because I think that was a really important point to make. And the answer is that there were. 40% of the patients had heart disease, like our patients. And for that reason, I don't think of this as a big factor. I'd be curious to know what you think.
Yeah, I think maybe that's what we come away from the data that you showed us so clearly, that there doesn't appear to be, in terms of cardiovascular risk from a whole variety of different angles, a difference between what we understand well in terms of current ESA drugs and HIF-PHIs with cardiac disease. I guess I'll just throw out there, if you did have this patient and they were stented fairly recently, maybe I shouldn't do 7 months ago, maybe I should do 2 months ago. If you were treating with a POET and alpha, do you treat differently? Do you treat differently? If you have a patient who had an MI 2 months ago, they're on dialysis, they have stents in place, raise your hand if you treat differently with ESAs than in other patients. There's not a lot of hands up. No. What do you think?
No, I don't. I don't. I don't, because I feel like those patients were in the trials. So I do not.
That's right. Those patients were in the trials. We understand this patient population. I have colleagues of mine who, if there was a recent stroke, they use EPO a little bit more conservatively, maybe from the TREAT study and related data. And you have about a minute, I guess, before the questions, but this is a case of ESA hypo response. I'm curious for you, do you go up to higher ESA doses? Do you try to stay away from them with current therapy? And do you see a place for HIF-PHIs in the hypo-responsive population? I just made a case that I do, so I'm kind of out there on it.
Yeah, I really learned a lot from your talk, actually. I thought you made a really good case for it. I don't think we have fantastic trial data on it. The number of people who were hyper-responsive in the trials was small, partly because trial patients tend to be healthier, et cetera. So I'd like to have more data, but I think it's a very reasonable approach for the reasons that you said. And I do try to avoid high doses of ESAs, and that might be voodoo because those people were in the trials too. So perhaps I'm being inconsistent, but it makes me a little uncomfortable giving big bolus doses of ESAs. So I'll say that. We actually got a question that is a little bit related that maybe we might bring up, which was about, can we comment on the cost difference between these drugs? And so, I mean, the short answer to that is no, we cannot. At least I cannot. That's not something that I know anything about. But what I can say, though, is that any drug, regardless of the cost, if it works in hyporesponsive patients at similar doses to how it works in other patients, it will be it will be cost effective. It will likely be cost effective. The higher the baseline ESA dose, the higher the cost of the ESA, therefore the more likely to be cost effective.
Yeah, that's a great point. And I mean, no, we're not going to talk about price. We're not going to, but that's a good point. That's, hyperresponsive patients do end up being costly to the health system. So right now it's questions and answers, and I'll turn it over to Dr. Johansson in terms of the questions that you've submitted already. But please feel free, because you're going to think about other things. Raise your hand if you have other questions. Jump up. Just yell out your questions. But I guess we'll start off.
We got some good ones here. I want to thank you guys for your responsiveness to the questions we got and to sending in these questions. This has been really great. But here's one that I think is really good. And this is for you, Steve. I'm giving it to you. Considering the addition of an oral drug to patients already on a ton, and that's capitalized, ton of meds, do you feel they'd really prefer a PO option over injection at dialysis?
Yeah, so look, that's a very fair question. And whoever asked it, thank you, because, I've tried to, New Year's resolution for 2020. I mean, it wasn't really a resolution, but I am trying to be more focused right now on the huge numbers of meds that patients are on. And I'm trying to stop a drug as often as I can in the patients that I have. So using another oral medication, that's a fair question to ask. And you want to increase the burden. I will say, it is a once-a-day drug if it's a peritoneal dialysis agent. So it's one pill in the morning. I don't think there's any interactions. You could take it about the same time if it's vadadustat. If it's at dialysis for hemodialysis, it's given at dialysis. I think this is the way it'll work, will be that, because it's not the way that it was done in the studies, right? But
right.
I do think that it's probably going to end up, my friend Jay Wish says it'll be 3 times a week at hemodialysis.
Yeah.
But very fair point. Whoever asked the question, thank you for that.
Yeah. Thanks. I mean, that's my thought is, and I think that question is important because we should never forget about patient preference and patient choice. So my thinking is that would be preferable for a home dialysis patient than coming back into the clinic one or more times in between visits to get injections. But if the patient doesn't think that, then maybe this isn't the right treatment for them. And so I do feel like we should consider that. What do our patients
Yeah, or maybe the patient likes to come in, maybe they want the social contact, maybe they want to be seen by a nurse and feel that, they're being assessed. So, right, it's not as simple as just saying that it fits for all patients. That's a really good point.
Yeah. Let's see. So we have a couple of other ones. There are more coming in. Are there significant drug interactions to be concerned about with vadadustat?
So I'm hoping you're going to quickly answer that question. I do not believe there are significant interactions, but what I really should say is I'm not sure the answer to that question. I'm not sure the answer to that question.
I'm not either. I mean, there are a few liver enzymes, but I think there aren't a lot of interactions with the drugs we commonly use. But I do think, again, as an oral agent, we don't want to administer them with binders. So
Potassium binders.
yeah. So I think that's a concern potentially. I feel like perhaps this question came in before Steve was finished, Dr. Fishbane was finished talking, but maybe it's worth repeating anyway. If vadadustat reaches the same targets as ESA with more or less similar side effects profile, why when switch dialysis patients to it as compared with others?
Yeah, so if you get the same results, so if you're fully convinced that the efficacy, safety are exactly the same with this oral agent compared to just giving injectable darbepoetin, epoetin, Mircera, why not just keep doing what we're doing, which is having nurses give injections? And I think, again, it comes down to if a patient's not doing well on EPO, if they're hyporesponsive, maybe that's a patient that you think about. But I have to say, it's interesting. I run a dialysis program with 19 dialysis units, and I asked the nurse directors at the different units. Some of the nurses said to me that they would actually prefer to get away from having the nurses run around giving injections, would rather have them do assessment and education, and would prefer to be able to just hand the patient an oral drug. But that was the minority. Most of the nurses didn't say that. Most of them said, we already know what we're doing. It's easy to do, and we'd like to just keep doing that. So very fair question.
All right. Please feel free to raise your hand if you'd rather ask a question that way than this way, but there are more here, and so I'm going to keep going for another 2 minutes or so. This one relates, I think, to something you said pretty directly. Is there actually evidence for adding vadadustat to ESA in case of hyporesponsiveness?
Right. So this is that question. If you're going to treat for ESA hyporesponse, should you take the patient who's not doing well on the ESA, the hemoglobin is 7.6, they're on a high dose, and just stop the ESA, or should you add the HIF-PHI on top of that? There's a KDIGO practice point, and it's not finalized yet, but it's already in the public domain, so I can say this, that KDIGO is recommending against doing that, against adding the two drugs together, because we don't know yet whether using the two drugs together is necessarily safe, and they'd like to see data before that is used. I kind of feel a little bit differently about it. Basically when you're treating with epoetin, for example, you're giving the patient erythropoietin. If you're treating with a HIF-PHI, you're giving the patient erythropoietin. Admittedly, there are some other effects of that, but you're getting that whether or not the patient's on EPO. It doesn't make sense to the crazy way my brain works in terms of logically why there would be a different. And I worry a little bit with this ESA hyporesponse that I'm just going to stop the EPO. Maybe you use them both together for a little while. I don't know. Do you have thoughts on it? I don't know that there's
well, I mean, the trial data that I showed, the phase 3 trials were comparing one agent to the other. So there are not large phase 3 trials of combining the drugs. So if you want to be a purist about it, that's the situation. But Steve makes a really good point. It's not, these drugs are taken by a different route. They have different mechanisms of getting to the same place. So it's not clear that the toxicity would necessarily be the same or be additive by doing that. We got a question about insurance coverage, which, in the last few seconds we could talk about that, because in theory that could be a problem, right? That, giving two different drugs for the same thing. However, these drugs, at least right now, are going to be in the dialysis bundle. So there's unlikely to be, well, at least for the patients covered by Medicare, which is the majority of dialysis patients. So it might be a matter of convincing dialysis providers about what protocols should be. One last comment I'd make on that is, and again, I don't know what Steve will think about this, but when I think about those hemoglobin data that I presented, each agent had slightly different protocols. Roxadustat, if I remember correctly, overshot the hemoglobin on their dosing initially during the titration phase. Vadadustat, as I showed you, underdosed a little bit in that titration phase. And daprodustat was almost right on in that titration phase. I think that's only a dosing issue. It's just a matter of figuring out the dose. And so since vadadustat underdosed a little in there, could you consider, if you did swap, starting with 450 instead of 300? Since in the general population you overdose, what do you think, Steve?
100%. And a good place to end the program is with 100% agreement. So I'm totally with you. All
right. Well, I think that our time is up. I really cannot thank you again enough for being such a responsive, participatory audience. Thank you very much for your good questions and your attention.